what's happening in San Diego and how we're clearly out front and one of the leaders and how we're understanding, engaging, treating, involving, inspiring older adults in our community to make sure that older adults live a better life. So to move that along, we have this exceptional panel. You'll find that out. I'm just impressed that they all said yes and came here today. Afterwards, we'll have up on our website their bios and everything else. Right now, just know they're brilliant. They care passionately about older adults, and we're in for a treat. And so when you speak, each of you just introduce yourself, and then we'll go on.
Excellent. Well, Steve, I agree. We have an incredible panel here, so we could probably go on for hours, and I know you're not going to let us do that, so I'll be looking to you. And I feel like, we're aiming for something conversational, but I feel like I need to grab that gavel over there, and we could just, so it be moved. Geriatric care has been transformed in this setup here. But no, this is a perfect continuation of what Dr. Yorman was just talking about. We're here to talk about geriatric care transformation. And, as Dr. Yorman mentioned, I mean, we have this aging population, which is really remarkable, right? The fact that we're here today because we had a 30-year gain in life expectancy over the last century. And so now kind of what do we do with that? We're very lucky today that we had 2 geriatricians in one room. That's, with only less than 7,000 of us in the entire United States. Any other geriatricians here? No. Okay, well, we had 2. I'm a geriatrician, Dr. Yorman, so that's good. We have this aging population. It's a great achievement, but there are challenges that come with it, obviously. You heard some in the talk, but, the increased prevalence of chronic disease. We know that 2 out of 3 people over the age of 65 suffer from multiple chronic conditions. And within that, also dementia. Thankfully, the incidence of dementia has gone down, but the prevalence, the sheer amount of people living with dementia and predicted to be living with dementia in the near future, the numbers are astronomical just as a function of the aging population, because age is one of the biggest risk factors there. We have a system that's really oriented around sick care as opposed to truly health care, and a system that is very fragmented. And this divide between social care and health care. There are issues around access and trust, and those are very much connected with this loneliness epidemic that we were talking about this morning. There are terrible inequities in care, inequities in access, inequities in outcomes, financial challenges, including the forgotten middle, the sort of people who are above safety net services and don't have the resources to afford some of the things that we so desperately need. And then, of course, workforce challenges, which we'll talk about more later today. So, I mean, that's a hefty list. So we're looking at, there are many challenges. And through this conversation, we're going to talk about some of the efforts to address those challenges and hopefully end by really looking at some of the bright spots. But I turn it to each of you, if you could tell us a little bit about yourselves, and are there other things that you would add to that list, or any other comments you would make on that list of these very significant challenges we're facing?
Great. Thank you so much. Hi, everyone. I'm Danielle Glorioso. I'm just so delighted to be here today, and I'm honored that Steve invited me to be part of this esteemed panel. I'm a social worker by training, and I also am the executive director of UC San Diego's Center for Healthy Aging and the Stein Institute for Research on Aging. So my perspective is going to be a little bit unique today because I'm going to be coming at it through the lens of academic research and interventions that we're developing to innovate and help transform geriatric care from this other lens. So with that, I'm just delighted to be here today to be able to partner with all of you.
And hi, I'm Erin Westphal, and I'm a program officer with the SCAN Foundation. I'm a gerontologist, not a geriatrician. And I think what's really great is that people are starting to know what the difference is between those two. And I actually did my undergraduate work at San Diego State. So Nice to be back in San Diego. And at the SCAN Foundation, our work is all about improving the lives of older adults. And we do that through systems transformation. So I'm committed to not getting super wonky with you all today because like talking about the nuance and like public policy and legislation that's available and the implementation of that is just what makes my heart sing. But thrilled to be here and to share more information. And I think that while the list that you provided was pretty comprehensive, I think one of the things that we have been learning that's really important as part of the work that we're doing is how to reframe aging. And I think that that's one of the big challenges that exists is that oftentimes when we talk about what's happening in aging, we start from a place of maybe catastrophic doom and gloom. And what we know is that actually shuts people down. And so if nothing else today, I hope as we think about the challenges, what people walk away from is like starting from a place of opportunity when we're talking about aging as instead of a place of deficit.
That's such a good point, and so I don't want anybody in here to use the word silver tsunami anymore, right? Because we know, first of all, tsunamis come without warning, and we've known this is the demography's destiny. We've known this is coming, and it's a great opportunity. So let's call it the great age wave, which we're all riding together. This is great. And I didn't mention, so I did mention I'm a geriatrician. I'm also the founder of a company, Determined Health, that is focused on geriatric care transformation, very much starting by addressing social isolation, loneliness, and trying to bridge the divide between healthcare and social care. But I know you said you weren't going to get wonky, but I'm going to start with a little bit of a wonky thing. So again, we've known this is coming, and thank goodness we've had the foresight, and we actually have a master plan for aging. It was referenced in the talk this morning. So can you tell us a little bit about this master plan for aging and how do the goals in this plan support the changes in care that we need?
Sure, absolutely. So this is one of those other things. I think when you're thinking about policy change and system change, you have to be in it for the long haul, and you have to really work to start positioning things. And so I'm really grateful that when our last election for governor, because I can't say gubernatorial, like I struggle with that word, is that Newsom and the other person running, they both committed to, if they were elected, developing a master plan for the state of California. And our partners at Westphal, who have been mentioned today, were a part of that work with the SCAN Foundation. And it was amazing. It happened. And when that master plan for aging was released was not a great day because there was some stuff happening at a federal level with our transition of leadership. But what is great is you saw today that there are these 5 components, and I won't go over them again, but I'll really focus on that health one since that's what we're talking about today is innovation and geriatrics. And I think what is important about the master plan for aging is it's about bringing together all of the different departments, all of the different sectors to really work in a coordinated way to improve the lives of older adults. And we just heard about the 8 and 80. That's the thing, is like when you make something better for one segment of the population, it actually makes it better for everyone. And so within that health category, that health domain in California's master plan for aging, it focuses on a lot of things that we're talking about today. So how do you prepare a workforce? How do you make sure that you have enough workers and that they are prepared and compensated for the care that they're providing? How do we think about having culturally appropriate care? So those are our words, right? As professionals, culturally appropriate care. But if you ask an older adult, they'll be like, I just want somebody who like speaks my language or is from my community. So that's what we mean when we think about culturally appropriate care. And then also, there are big things like California's CalAIM, which is, again, super wonky, right? Integrated care for dual eligibles. All these DSNPs are being developed. you all in San Diego are ahead of the game because you were one of the demonstration counties, but now it's going statewide. And so there's a whole robust set of benefits within that are across lots of different departments at a state and county level. And what California's Master Plan for Aging done is saying, how do we integrate and coordinate those together with the ultimate goal of ensuring that older adults have what they need so that they can age in the community or the setting that they want. And so I think that that's a really critical component and piece of the success around this.
Yeah, that 8 and 80, that kind of universal design principle that when you put curb cuts in, that it's good for people who are pushing a stroller or using a wheelchair, right? Just kind of better for everybody. So Danielle, when we think about the master plan or just general innovation, it really is kind of an all hands on deck situation. And so as someone who helps lead an academic aging center here in San Diego, what role do you see aging centers, both locally and nationally, playing in this important geriatric care transformation work?
Yeah, this is a great question, and we're playing a massive role. So when you think about, so the Stein Institute's been around for 40 years. We were the first organized research unit in the state of California dedicated to looking at aging. And about 20 years ago, we decided to completely change gears and start focusing on successful aging and healthy aging, the things that go right with aging. And believe it or not, 20 years ago, people laughed at us because these terms, healthy aging, successful aging, they've been around, but they weren't household names. So, real scientists and researchers would sort of laugh at us like, why would you do that? You really want to be focused on disease and disability. And I'm so proud to say 20 years later, I don't know that there's a single state in the United States that does not have an academic institution with a center dedicated to healthy aging and successful aging. So it's just, and some states have multiple. So what that tells us is that people care about healthy aging and successful aging. People care about focusing on how to help people adapt and be resilient in the face of disease or disability. And that all of these academic institutions are doing it through their own unique lens, right? So even if you just look at the partnership that we have here with CEAL at San Diego State and UCSD, we're both focused on this area, but in very different ways. So it truly is that we are greater than the sum of all of our parts, right? And so as academics, one of the things we do is we think about ways to innovate, right? Because we focus on ways to get grant funding. And so when you are looking at grant funding, you have to think about ways to innovate and do things differently. And so that's what we focus on, is like, how can we take an issue or a challenge and partner with older adults, learn from older adults what matters to them, what do they care about, and how do we address those changes with them in partnership? And so that's one of the ways that we're tackling it at UC San Diego. And that seems so obvious, right? Like, partner with the people you want to help, but it's actually not that obvious. And so that's part of the work that we're doing. And we really do see that across the country, interdisciplinary work, engineering, computer scientists, sociologists, all of these different groups working together to help transform geriatric care.
Yeah, oh my gosh, we're gonna have to come back to some of those themes because the interdisciplinary, it's an art and a science too. It's not just having a bunch of people in separate cubicles doing things individually, really getting people
Yes.
to work together. So Erin, coming back to you, you brought up CalAIM, and obviously, if we're gonna do a good job taking care of an older population and providing good care that delivers the things that matter most to people, government payment, Medicare, Medicaid, it's always going to be a big part of it. And so now CalAIM really really opened up a whole new landscape in terms of, for people with Medicare and Medi-Cal. How do you feel that the goals of CalAIM have supported integration and coordination of care for those who are eligible?
Yeah, that's a big question. I just want to reiterate what you were just saying, that including the voices of people who are impacted by these programs used to be the exception, and we're trying to move it to being the rule when you're developing a program. I think, we've been doing work related to California's duals integration from the start with the 7 counties and continue to work with the state and with the plans now statewide. And I think that with so many policies that are put into place, it's you can look at it and you're like, yeah, this is fantastic. It's like making sure that all of the providers are talking to each other. Everybody's using the same care plan, that it's based on what the individual needs. But the devil is really in the details. Like you can, and I'm not bashing health plans here, but you can look at a health plan and they will say, of course we do a comprehensive assessment. Of course we have a care plan. Of course we do all of these things. And they do, but it's like, well, what's the essence underneath that? How is the person showing up in that? How do they know what the coordination is? What does that mean? And I think that one of the things that really stood out for me, which from our keynote speaker, is how she was saying, well, you can go in and you can put in all this information and then you take this document and you give it to all of your specialists. And our system is designed right now where actually the individual and their caregiver, they are the care coordinator. And I think the promise, the aspiration of CalAIM is that they aren't the center. They aren't the people that our system knows and our system is coordinating. And we talk a lot about how if you are somebody who's eligible for both Medicare and Medicaid, Medi-Cal in California, that you have a robust set of systems, of programs, of services to help you age successfully in place. But navigating that is a nightmare. I'll tell you, today, before this meeting, I was on a call where we were talking with a group of really smart people about how to map the home and community-based service system that people are eligible for. And we couldn't figure it out because it's so complex, and it's not only different by every state, but it's different by county. So it's this really complex system. Goal of CalAIM is to reduce that complexity. The devils are definitely in the detail, but I also know that there are a lot of really amazing people in plans that are trying to figure that out and are also tackling issues where I'm on these calls with the plans and they're like, well, this field allows for 20 characters and I have 21 characters. So like, what am I supposed to do? And so they're very stuck in this, making sure that they're following all the rules while trying to think about, well, in a rural community, what does network adequacy look like? And they're thinking about specialists because there's just not enough specialists in rural communities. And we're pushing them to think about, we get it, you have to have specialists, but how are you thinking about those home and community-based services? How are you thinking about the coordination with them? So again, aspirationally, I think it's amazing. And it's really about supporting as we move forward and knowing that the state has been a great partner in thinking through that.
No, keep going, share more, because the, being on those calls, you've had this perspective, right? Where you get to see, because some of these things, again, are just like, it's not rocket science, but this no-do gap. I love that. The no-do gap that Dr. Erin mentioned. I mean, so the idea is really care that's more community integrated, and that, CBOs are at the table and not even at the table, really driving the care, right? I know for us, we have programs where we match people with a friendly caller. And the whole idea, again, is to be able to really get to know the person, understands what matters to them, integrate that information back into the care team. And, with solving for loneliness, we know we should be doing that, but why isn't it in the water, right? And is it the constraints that the plans have to face in terms of those 21 character limits where they have 20? Or, I mean, what's stopping us from getting, it's like right there, we can see what we should be doing. Where do you think kind of the friction points, or some examples of friction points that we could overcome?
So we have a system that we designed, and we designed a system that's really complex. And I think that we also continue to make changes to a system without removing previous things. And so that makes it more and more challenging. I also, we heard this morning as well is, I think that by and large, I call them real people. I'm not a real person, so like real people who don't live in the space. By and large, real people don't think about these issues. And if something happens, people believe that the healthcare system can solve it. They actually can't. um, and there are some that are doing really innovative programs and doing more, but and we heard, I think the statistic was half of the people are going to need to have some chronic condition. We've done some work, and the general public believes that Medicare will address those needs, and Medicare will not address those needs. And so we see this space of people continuing to go to their healthcare sector to solve their home and community-based service, those ADLs and IADLs that we heard about this morning, those needs. And within the healthcare sector, we did some work once where we were like, well, it was this test of like, well, give us your 100 like most challenging individuals, patients, and we will reach out to them every other day. This was like a research, and then if they like flag that something's going on, we'll alert you. And the healthcare system was like, but we have no system in place to respond to that alert, and you're collecting the information, we aren't, so we don't know that it's valid. And then like that changes our risk and our liability. And so it's just like, it's complex because we designed a complex system.
Yeah.
So, and I think the other thing that I'll stop is that, and this is where I think it's fantastic. The promise of CALAIM, and really when we saw these changes with the Affordable Care Act, and I know that San Diego participated, about how there are more and more flexibilities on the Medicare side to be able to pay for home and community-based services. And the healthcare sector is going to build or buy those services. And the work that we've been doing to support community-based organizations to be the ones which they buy it from, because community-based organizations, they know their community, they know the individuals, and they can provide support. But again, it's the devil's in the details, how it all comes together.
Yeah, devil's in the details and crazy complex system. And Danielle, so much of what we're talking about is really dancing around what we know about social drivers of health. And you're a social worker, and I know we have social workers in the room. Yeah, so good.
Yay, social workers.
And so can you just talk to us a little bit more about, social determined social drivers, and what you're seeing in terms of unique ways that interventions are sort of tackling these root drive factors to transform care?
Yeah, I first want to say shout out to all of my social workers out there. I can't say enough about the meaning and impact that all of us social workers have in our field. The things that we face and think about, and the things that keep me up at night as a social worker is like social isolation and frailty and financial instability and caregiver burnout and grief and loss and disability and challenges. And so as social workers, on the front lines, we are innovating all the time. We're innovating in the way that we work with our clients, and we're innovating in how we see how to address the problem. And so I would say that I have been so honored and blessed in my role at UC San Diego, working in academics, that when I see a problem or an issue, I get the wonderful opportunity to sort of think about how to address it, and then develop something, and then test it and see if it works. And then if it works, find ways to try to implement it. And so one of the things that I have been focused on is the area of resilience. And so when we think about resilience, the literature has been fascinating. What I didn't know is that people who have high levels of resilience live longer. People who have high levels of resilience have better immune systems. People with high levels of resilience have better mental health outcomes, better physical health outcomes. I mean, it's fascinating. And so I started to think, I wonder if we can develop something that will help enhance resilience, because, all of those things really matter and can make a difference. And so I developed an intervention 6-week intervention to work with older adults to help them enhance their resilience, wisdom, compassion, self-compassion. And then thought, okay, I wonder if I can adapt this for people who are struggling with loneliness, because loneliness has become a public health crisis. And then I wonder if we can adapt it to use it with caregivers who are struggling with the competing demands of caregiving. And then also, after they lose a loved one, like up to 25% of those develop something called prolonged grief, which is another serious and challenging mental health crisis. And so having these opportunities as a social worker, I see that's my experience. But then if you look across the country and across the world, social workers are coming up with real time ways to address all of these problems and challenges, because we get to interact with the older adult, hear what matters to them, hear what they're struggling with, and then find ways to address those things on the individual level. So it's really, I feel so proud to be part of this profession.
So I might have missed it because I was just in awe of both of you here and so lost in thought, but can you explain what resilience is?
Yeah,
Base-
so this is a great thing, because when you think about it, like everybody's heard the term resilience, but what does it mean, right? So some people will say like, well, does that mean you just haven't had challenges? And absolutely not. It's our ability to adapt and bounce back in the face of challenge. And so it is sort of finding ways to help us respond and adapt to a challenging life situation, financial situation, loss of a house, loss of a partner, loss of something that mattered to you. So how do we sort of face and adapt those challenges and adversities is what leads to resilience. But it's not a stable trait. It's a trait that can be enhanced and developed. And that's what my program has been focused on.
Amazing, amazing. And so now, Erin, so much of what we've been talking about today is really about getting down to what matters most. As you said, these are really complex systems, the devil's in the details, but yet, and there's fragmentation, I mean, all these things, but yet we tend to, unfortunately, do things Sir Ivory Tower down all too often. And you guys have been doing some incredible work at Scan Foundation that's really sort of rocking that whole paradigm. And you released a report last year, Voices of a Movement. And then later this year, you're releasing something with the Public Policy Lab. So can you just tell us about this work and what's this all about elevating community voice of people with lived experience? Would love to hear more about this.
Yeah, it's super exciting. We started a number of years ago learning about human-centered design, and I think those curb cutouts are a prime example, right? When you solve for people on the extremes, you solve for everyone, any issue. And we had our new CEO, Sarita Mahanti, came on board in 2021 and said, everything we do has to be informed by the voices of older adults, and not older adults writ large, but older adults from marginalized communities. Those are older adults of color who are low income, which we're defining as 300% of poverty or below. So that includes the forgotten middle, as well as those that live in geographically underserved areas. So rural communities, but even an urban community that that's a food desert. And we our work on Stories of a Movement we did here in California, and we worked with Greater Good Studios that went and spent time with older adults in their communities. And yes, San Diego is a part of it. And I will say that the things that the older adults said, we could have summarized them. Biggest issues: transportation, housing, affordability. But again, we were like, that's not what this is about. This is about hearing these issues from the people's voices. So when I talked about, we say culturally appropriate care, but older adults are saying, we just want somebody that looks like us, that speaks our language. That's where that work comes from. And so using that to inform the work that we're doing. Prior to that, we worked with Greater Good Studio to collect that same information to inform California's master plan for aging, so that older adults' voices were in that space. And our latest project, as you mentioned, is with Public Policy Lab, where we have gone to 8 states and we've talked to older adults and embedded them embedded ourselves in those communities. And the intent is to be able to elevate these stories. So when policymakers are making decisions and maybe they can't, or it's not a priority, to go and hear from the voices of people, they can hear the stories through this work. It's being there. And I will also say that on with the master plan for aging, our governor says often, like, as goes California, goes the nation. And within that work, we've been able to support other states. So there are now 26 states, including California, that are replicating or doing what California did on they call multi-sector plans for aging. And core to that is talking to the community, having the communities develop and inform that. And what's super exciting to me, in this kind of wonky space, is that now the federal government is creating what they're calling a national framework for aging. And it was mandated by Congress and agreed to by our president. And it's, again, this cross-departmental and elevating the voices of people with lived experience. We're holding a series of listening sessions across the nation. The SCAN Foundation is supporting that so that those voices are a part of what the federal government is developing. And again, going from the exception to the rule of making sure that the voices are there. And just I'll say one last thing and then I'll stop. We were having a meeting yesterday in San Ysidro, and somebody said, well, this isn't about like sharing power with older adults and like helping them find their voices. It's about us being quiet and letting them use their voice, and about us actively listening to what they have to say. And I think that that really gets to that paradigm shift of it's not that like we know what's best for you, rather tell us what you need and tell us what you want, and how can we make that possible?
Amazing. Yeah. So, okay. This is probably overly confessional, but it's just become clear to me in this conversation. I'm a wannabe social worker. Just out me right here. I'm now a wannabe San Diegan. Just amazing to hear about all the bright spots here. And I've been really enjoying the partnership with SDSU, and now learning about what you're doing at UCSD. I know you have geriatricians there who are heroes of mine, but also just the nicest people I know in the world, with great research. So it's amazing how you're known for your robust focus on aging, both in research and clinical care. So could you just tell us a little bit more about how UCSD geriatric care is driving innovation and ways that might be something we can export?
Yeah, I'm going to brag a little bit because I'm so proud of UC San Diego and what we have done and what we are doing to innovate in this space. And I think when you have the opportunity to be an academic institution that also has an academic hospital, you can really innovate a little faster, because so much of the challenges we face as researchers is implementing the work, right? So we come up with these great ideas, we test it, and then like you can't get it out to the people who need it. So you can do that a little bit faster at an academic hospital and university. So one of the ways that I'm really proud of, I didn't have anything to do with it, but I'm super proud of it, is our geriatric emergency room. Did you know that we have the first in the state cutting edge geriatric emergency room? It's an incredible facility. Co-sponsored by Gary and Mary West Foundation. So people came up with an idea, they innovated, and they made it happen. So we're also doing that with our students. So last thing I'll say on this is sort of thinking about geriatric workforce and how to transform care. We work with the students to help them better understand older adults so that they are prepared for the workforce and to make a difference. So we work with, say, engineers, and the engineering students want to work in developing novel solutions for older adults, but they don't know the needs of older adults at all. So then what we do is we pair them with an older adult. The older adult tells them what they need, and then the student designs a solution around it. And then, again, this should be the way it is, but it used to be that they would design a solution that didn't meet the needs of the older adult. So we can sort of make that stuff happen real time and bring it to life for older adults.
Okay, so as we wrap up here, let's just really hone in on, bright spots, things that were make us most optimistic. You know, we started with the challenges, and I just want to, you know, I've been digitally stalking you guys a little bit here, and your background, I'm really interested in terms of how it informs your perspective. I also love that you love writing letters to pen pals and want to know more about that. But just in case there's anybody who thinks, you know, these Johnny come latelys, in 2015, you penned an article, How to Get Better Care with Lower Costs. See the person, not the patient, right? Or Managing Chronic Disease in an Evolving Healthcare Environment. Community-based organizations increasingly are addressing social determinants of health and preventing more expensive medical interventions. So clearly, you know. So now what are you seeing and where do we need to go?
Wow. I think that letter writing is a dying art, and I would encourage everybody to. There's an organization called the Letter Writers Alliance, and for $5, you can have a lifetime membership.
Oh.
Anyway, so, but I think that just off the fly, making an analogy with that, I mean, letter writing is about taking time, being thoughtful. Like it's very tactile, right? You get, well, at least for me, like I make my own stationery too. I have a letterpress machine in my home and I carve blocks and I set type. And so it's this like really thoughtful thinking through designing aspect. And it's about connection, and that letter writing being about a connection to a person. And so, again, just my on the fly analogy, I think that what I'm hopeful about is that I'm seeing this intent with the policies that are being discussed and the policies that are being implemented to get back to that intentionality of connecting with people and meeting with people and trying to deliver care based on what they want. And that gives me a lot of hope. But again, we've got the super dysfunctional system that's designed in a way that we sort of have to dismantle. We have to get back to those basics. And some could say, well, we've been doing that for the last 40 years. But we just kind of have to keep going. And I think we also have to celebrate those incremental wins. And really uplift the people who are making those changes.
I'm going to definitely stick with that metaphor in my future. I mean, and I think we should be drafting a love letter to our future in terms of transforming geriatric care. And outing myself for the last time, I'm a total rom-com nut, so I'm a softie. But anyway, Danielle, you've had really interesting career transitions, found your way into this field. You had some personal experiences that were really formative in terms of your clinical care and your research. And again, just to give some of your greatest hits real quick, high prevalence and adverse health effects of loneliness in community dwelling adults across the lifespan, role of wisdom as a protective factor, 2019, age-friendly communities, 2016, association between older age and more successful aging, resilience and depression, you spoke about that, 2013, pragmatic trial of group intervention in senior housing communities to increase resilience, and that's more recent. So what are you excited about? What are the bright spots for you?
Well, I want to first start with Erin. How do I become your pen pal? I need to get on that list. Your stationery sounds so nice. Well, to be honest, I'm going to answer it with something you wouldn't expect from a social worker, which is I'm really excited about the work that's happening in biomarkers and aging, which is totally over my head, but I'm fascinated by it because the idea of personalized medicine really is so important. And so when you look at some of the work that's happening across the country and across the world, in fact, our scientific director, Dr. Anthony Molina, is doing a study to look at resilience through the biological marker lens, which is this idea that like when somebody has a high stress event like a fall, why do some people with similar physical characteristics sort of bounce back faster than others? And so if we can sort of better understand the biological markers and what predicts those things, we can treat the person in a more like concentrated way, we could make a real difference. So sort of the colliding of what personalized medicine can do for older adults and then the social work side and all the other pieces, I think could really help transform the field and the way that we give care to older adults.
Amazing. Again, we could go on all day, but I've done my job of keeping things
Yes,
on
you
time.
did.
Looking at you, Steve. Here we go. And I love where we've landed. I feel hopeful. I feel confident that we really can architect a better future of aging. And this seems to be an epicenter and a real opportunity for us to align care in ways that nobody else has done. And it's good to be here.
Thank you, everyone.